Good afternoon. Thank you for the invitation. Today I will present advances in management in neuro-oncologic genetic tumor syndromes. As you may already know, brain tumors are seen in numerous one second. In numerous tumor predisposing syndromes, but only 5% of gliomas are reported to occur with family features, suggesting that treating physicians under-recognize these syndromes in their practice. For this reason, identification is critical, not only for the patient, but also for the surveillance and risk reduction for the family members. There are several tumor predisposing syndromes, but today we will discuss about Lynch syndrome since these patients may be potentially treated with immunotherapy. Lynch syndrome is an autonomic dominant genetic syndrome with abnormalities in the mismatch repair genes MLH1, MSH2, MSH6, PMS2. Lynch syndrome is one of the most common hereditary cancer syndromes. It's estimated to happen in a general population between 1 or 1,000 to 1 or 250 people. The average risk to develop a brain tumor from Lynch syndrome is approximately 5 to 8% in patients with MLH1 mutation. But this percentage can be higher in patients with MSH2 mutations, up to 13%. As you can see here in the right side, there is a graphic. In tumor cells, the mismatch repair gene complex recognize DNA replication errors. Then there is an excision of this area and replacement or repair. But in patients with cancer, there is a mutation. It can be any of these four previously mentioned genes. The most common in Lynch syndrome because of colon cancer is MLH1. But these mutations only happen in one allele. During the course of life, there is epigenetic silencing of the other allele and manifestation of the tumor or cancer. This mutation also can induce accumulation of mutations and new neoantigens. And this condition is called hypermutator phenotype. It's important for the immuno-oncologic therapy. Okay. So there are some red flags, and in the clinic we use the standard criteria for healthy individuals, just for the recommendation of further genetic testing. Those patients needs to have 3 relatives with cancer linked with Lynch syndromes, one of them a first-degree relative, and in 2 successive generations. We also use the revised Bethesda guidelines. This is in patients who develop colon cancer, already have a cancer diagnosis, but the onset is early, in younger than 50 years. These patients also need to have a second cancer or a first degree relative or a cancer into successive generations. Okay. Tumors reported in Lynch syndrome will include gliomas and skull-based tumors. As general rule, glioblastoma is a cold tumor. 2/3 of these cases have no detectable lymphocytes. Only 10% of the cases present with lymphocytes in 50% of the tumor volume. But these tumors, these T cells that are already infiltrated in the tumor microenvironment are expected to be heavily dysfunctional. That this can be a main reason why a phase 3 trial using PD-1 inhibitors for the recurrent glioblastomas failed to extend survival. During the last years, hypermutator phenotype is considered an important concept for the understanding of chemotherapy resistance and immunogenicity. It was first reported as in recurrent gliomas, glioblastomas after the treatment with temozolomide. It was identified mutations in the retinoblastoma and mTOR pathways. And these patients with elevated tumor mutation burden of 30 mutations or more per megabase also were observed to have resistance to alkylating agents. Temozolomide is known to induce mutations in MSH6, and these patients are the ones who are observed to have even more resistance to alkylating agents despite having the MGMT methylation. That is a biomarker to respond for alkylating agents. Other group that is considered hypermutator is the DNA polymerase gene mutations. And the hypermutator phenotype, it can occur in approximately 17 to 30% of the recurrent glioblastoma. In our internal analysis at MD Anderson, we identified 22%. So hypermutator phenotypes can confer immunogenic potential due to high neoantigen load and high levels of PD-1 expression. But the question is hypermutator glioblastoma responsive to immunotherapy? In our analysis, we identified 312 patients with a diagnosis of glioblastoma who underwent next generation sequences of the tumor. We identified that 22% of the patients were treated with temozolomide presented with this phenotype. But something interesting was that patients without any treatment with temozolomide also presented with hypermutator phenotype, and we call de novo hypermutators. These represent about 90% of the cases. For each group, we treat the patients with immunotherapy, and we will discuss our results in a while. In terms of the molecular features for each of the groups, for the post-treatment hypermutator, we identified that the most frequent molecular features were elevated tumor mutation burden. So that suggests that this phenotype was induced by treatment or specifically temozolomide. For the de novo hypermutators, we found that the most frequent was the polymerase DNA mutation and the mismatch repair deficiencies, suggesting that there is a DNA fragility in these tumors even before treatment with temozolomide. The clinical features also were different. The clinical course for the de novo and the post-treatment hypermutator show significant increase in the overall survival. For the de novo, the overall survival was about 28 months. For the post-treatment hypermutator was about 40 months. That is significantly prolonged when you compare with non-hypermutator glioblastomas. One of the explanations can be that these patients are already more sensitive later to temozolomide and radiation therapy. We then run the immunocyte profiling of these tumors. We compare hypermutator glioblastoma with non-hypermutators and stratify in IDH mutation or not. We found that hypermutators tumors have a different gene expression than the non-hypermutators, and these genes are associated with immunogenic functions. We ran also the cell type analysis, and the hypermutators have increase of that T cell infiltration, specifically CD8 T cells and cytotoxic cells, but simultaneously, there is a significant increase of Tregs. That is an immunosuppressor. So we theorize that there is a natural neutralization of a potential immunogenic tumor. These tumors also can present with significant PD-1 and CTLA4 expression. That's why we treat these patients with immunotherapy. We treat 10 patients, 9 of them had somatic mutations, and only one had the germline mismatch repair mutation, Lynch syndrome, in the MSH2 gene. From those 9 patients with somatic mutations, 60 to 70% of the patients have a hyperprogression. Hyperprogression is an exaggerated, rapid tumor progression with under the treatment of immunotherapy. It's seen in about 17% in solid tumors, but it was very frequently presented in gliomas. As we can see, the progression-free survival ranged between 7 to 10 weeks during immunotherapy, and unfortunately, the 6 months progression-free survival was 0%. However, the patient with germline mutation, the patient with Lynch syndrome, was started on pembrolizumab, a PD-1 inhibitor, and for 1.5 years, the patient have a stable disease and partial response of the tumor. Even that this patient was MGMT unmethylated, that represent a group not responding to treatment. Hypermutator phenotype also can be seen in meningiomas. We know that meningiomas can exhibit higher mutation burden, and also has been reported meningiomas with mismatch repair gene mutation. Okay. In addition, we know that recurrent meningiomas may have increase of the PD-L1 expression, specifically in grade 2 and grade 3. So this is one of my patients, 57-year-old male, that it presented with left side weakness and personality changes. This patient underwent surgery, radiation therapy, and unfortunately, this patient was recurring almost every 6 months, have multiple radiation therapies and surgeries. In 2019, patient have further tumor progression with almost complete resection of the tumor. The diagnosis was a grade 2 meningioma. But interestingly, the next generation sequencing show MLH1 mutation and NF2 mutation. Based on this, we decided to treat a patient with pembrolizumab, and the patient has been stable for the last 2 years already. This is another patient, 42-year-old male with diagnosis of Lynch syndrome. He has a germline mutation in MLH1 and MSH2. He underwent a subtotal resection. The pathology show again a grade 2 meningioma, and immunochemistry tests show no expression on MSH2, and the molecular testing of the tumor showed NF2 mutation and MSH2 mutation. The patient was started on pembrolizumab after surgery. The patient never received radiation therapy, and he completed 1 year of immunotherapy, and the following 6 months to 8 months has been stable with any sign of recurrent disease. During the course of treatment, he also underwent a CSF analysis. It showed pleocytosis with predominance of lymphocytes, suggesting that there is some immunogenic activation of the neuroaxis. And the patient didn't have any symptoms, no malignancy and no infections. Pituitary tumors also can present with this phenotype, also is described in Lynch syndrome. In addition to this, we know that pituitary tumors, when they become more aggressive or they become pituitary carcinomas, that is a stage in diagnosis, is a pituitary adenoma plus metastasis, have a higher expression of PD-L1. So the standard of care will include surgery, radiation therapy. Upon recurrence, the recommendation is temozolomide or temozolomide and capecitabine. So we have a patient, 36-year-old male with a history of functional macroadenoma. The patient underwent a gross total resection, radiation therapy, and then he was treated with temozolomide. Short after, the patient developed abdominal pain. He was found to have metastasis to the lymph nodes below the liver, and patient received chemoradiation with temozolomide. About 6 months later, patient developed intracranial tumor progression, underwent a partial resection. We analyzed that tumor and demonstrated elevated mutation burden of 76 mutations, and also mutations in MSH6 and MSH2. Patient was starting on pembrolizumab, and there was a good radiographic response, and you can see in picture A and B after 2 cycles corresponding of 4 doses of pembrolizumab. Beside the radiographic response, there was also hormonal response. As you can see, the levels of ACTH drastically drop to almost undetectable levels. And this patient never had this hormonal response with any of the previous chemotherapies. So as a summary, primary brain tumors, including skull-based tumors with hypermutated phenotype, can present spontaneously after treatment or inherited by Lynch syndrome. MSH2 and MSH6 gene mutation are frequently associated with development of primary brain tumors. Hypermutated glioblastoma may have a prolonged survival compared to those without hypermutated phenotype. And immuno-oncologic therapy seems to be ineffective in hypermutator with somatic mutations in the case of glioblastoma. However, can have a durable response in hypermutators with germline mutations, and also in non-glioma hypermutator tumors. This is my acknowledgement. Thank you.